Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Hello, I'm Nicole Konzin, professor at the Medical University of Vienna in Austria. Welcome to this program entitled Beyond the Update in Advanced and Recurrent Endometrial Cancer, How Evidence is Shaping New Guidelines. Joining me today is a fantastic faculty, Xavier Matias Guiu from Hospital Universitari Arnau de Vilanova in Lleida, Spain, and Els van Nieuwenhuizen from the University Hospital Leuven in Belgium. Welcome. During today's program, we will look at three major topics. First, risk stratification based on molecular classification and the new 23 FIGO staging system in the triple European guidelines from ESCO, ESTRO, and ESB. Second, we will focus on clinical trial data and how these tie into the latest updates from our triple European guidelines. And third, we will focus on patient cases, outlining how we can integrate guideline updates in clinical practice. And now I hand over to Professor Matias Guiu for the first topic.
So here you have the picture of the ESGO, ESTRO, ESP guidelines risk stratification, which is integrating molecular classification and parameters obtained by staging. You can see by the colors the different risk of stratification, and molecular classification is very important. It's very important to perform polymutation testing and then immunohistochemical analysis of mismatch repair proteins and p53. When the tumor has pathogenic mutations in the gene poly, the prognosis is very good, as it is shown in our risk stratification guidelines. The second group is the tumors that have mismatch repair deficiency. They have abnormalities in one of the 4 genes that are in the mismatch repair pathway. The third group is the tumors that are non-specific molecular profiles. Those are those tumors that do not have any polymutations, do not have abnormalities in mismatch repair proteins, and do not have abnormalities in p53. The risk is different depending on the staging. And it's very important to distinguish between the tumors that are low-grade and estrogen receptor positive than the tumors in this group that are high-grade or estrogen receptor negative. And the fourth group, which is the group that has worse prognosis, is the group of p53 abnormal tumors. In this group, we have the group of tumors that have abnormalities in the immunohistochemical pattern of p53, and NGS for p53 is required when the tumor has a controversial pattern of staining of p53, or it has a heterogeneous pattern of staining. So these 4 groups are prognostically important groups of tumors. and they should be integrated into the staging systems. And the ESGO Estro ESP guidelines follow the FIGO 2023 rules, and I will briefly summarize. For early stages, it's very important to distinguish between low-grade and high-grade tumors. For low-grade tumors, the staging is stages 1 and different substages depending on the level of invasion of the myometrium, and stage 2 when the tumor has involvement of the cervix or, and this is very important, lymphovascular space invasion. For high-grade tumors, the stage is 1C when the tumor is limited to polyp or limited to the endometrium, and stage is 2C when there is any myometrial or cervical involvement. Just a common, a very peculiar situation, which is stage 1A3, when there is a low-grade endometrial carcinoma in both the ovary and the endometrium by fulfilling several criteria, which is limited myometrial invasion, the tumor limited to one ovary, there is no lymphovascular space invasion, and of course, absence of any metastasis. So for high stages, stage 3 and 4, there is no difference between the histological type of the tumor. And of course, the stage depends on whether the tumor involves the adnexa or involves the pelvic peritoneum or involves the lymph nodes. And this is stage 3. Or stage 4 when the tumor involves abdominal peritoneum or there is distant metastasis. It's very important to emphasize the difference of staging depending on whether the peritoneum is involved is pelvic, and this is stage 3, or the peritoneum is the extrapelvic, and this is stage 4. And also, FIGO staging incorporates the molecular classification in a way in which the tumors that are limited, confined to the uterine corpus or the cervix, and they have a polymutation, pathogenic polymutation, they are downstaged to stage 1AM polymutant. And for the tumors that are confined to the uterine corpus or with cervical invasion, but have a p53 abnormality, they are upstage, and these are the main rules of this ESGO, ESTRO, ESP stratification by integrating molecular classification and staging.
Thank you very much, Xavier, for this beautiful explanation on one of the central pieces, really, of the new triple European guidelines, the risk group stratification. But in the past couple of years, so from the last ESGO ESP guidelines to the recent update of 25, a lot of new evidence arose, and particularly in advanced and recurrent endometrial carcinoma, we've seen tremendous new evidence from randomized phase 3 trial adding immune therapy into our treatment options for the patients. And we are now eager to learn about these phase 3 trials from Professor Els van Nieuwenhuizen. Please, Els.
Yeah, thank you, Nicole. These are the 4 trials, 4 phase 3 trials that actually revolutionized the treatment of advanced and metastatic endometrial cancer. The Ruby Part 1, Energy 18, the DEWE, and the ATTEND trial all included advanced and metastatic endometrial cancer, treating them with platinum-based chemotherapy as we are used to, and investigating the role of adding a checkpoint inhibition, which differs from the different trials. In Ruby, we had dostarlimab. With the Energy, we had pembrolizumab. In DOE, we had durvalumab, and in the ATTEND, they used atezolizumab. And they also had a maintenance phase, and there the maintenance phase duration differs between the trials. You have Ruby up to 3 years, Energy small 2 years durvalumab, and the ATTEND went on to progression. The Ruby part 1 was followed by Ruby part 2, and the DUE also had an arm with also a PARP inhibitor. That's the difference between the other trials, that we also investigated the role of adding a PARP inhibition into the maintenance phase. Let's first look at the DMMR population. All of the 4 trials showed a tremendous impact with adding checkpoint inhibition to the platinum-based chemotherapy, with very nice hazard ratios ranging from 0.28 in the Ruby trial to 0.42 in the DUE, very consistent throughout all these trials. You can actually map all the Kaplan-Meier curves onto each other, and they will look exactly the same. So this is truly very pivotal. We need to add checkpoint inhibition in the treatment of advanced and metastatic DMMR. Now, what about adding a PARP inhibitor? Let's look at Ruby Part 2 and the DUE. We're adding a PARP inhibitor in the maintenance phase. Well, actually, adding a PARP inhibitor does not lead to additional benefit in terms of PFS when we are looking at DMMR disease. Now, skipping to the more difficult population, the non-DMMR population, which is actually the largest population when we're dealing with advanced and metastatic disease. There, the trials show some impact of the checkpoint inhibition, with hazard ratios for PFS ranging in the 0.70s. Only the ATTEND trial is slightly worse, 0.92. But the impact is less profound than what we have seen with the DMMR population. Now let's look there to the Ruby Part 2 and the DUE trials. If we add a PARP inhibitor, does then improve the PFS for this population? And Ruby Part 2 and DUE showed that adding a PARP inhibitor further enhances the PFS benefit, with PFS hazard ratio of 0.63 for Ruby and 0.57 for DUE. Adding, of course, additional therapy, whether it's immunotherapy or immunotherapy and PARP inhibitor into the maintenance phase, will add toxicity as well. While looking at the DUE, for example, we see the percentage of patients that discontinued any study drug due to adverse events was actually about 90% for the platinum-based chemotherapy arm, 21% for the chemo IO, and 24% for the chemo IO and PARP group. So we have an increase about 5% in adverse events that will lead to discontinuation of study drugs, which can be deemed manageable. It's of importance. We did not see any MDS AML cases within the DUE. And most of the added adverse events was, of course, due to the immunotherapy and the PARP inhibitor toxicity. When we look at Ruby Part 2, there the toxicity is maybe slightly high. The discontinuation rate was slightly high at 36%. That maybe has something to do with the toxicity profile of both PARP inhibitors is slightly different. So we're adding toxicity, but deemed manageable even in this elderly population. So after all these clinical data, how does these data actually translate into the clinical guidelines that were recently updated?
And thank you very much, Els. So very important to mention that this was a joint approach of 3 major European societies, and the work span over 1.5 years to actually develop these guidelines and translate all the evidence into clear treatment recommendations. So I will briefly summarize for you the algorithm that the working group has developed for first-line systemic treatment in advanced or recurrent endometrial carcinoma patients with no prior chemotherapy except in the adjuvant setting. So as Professor Els van Nieuwenhuizen has beautifully pointed out, all trials, all 4 randomized phase 3 trials showed a very clear result in the dMMR patient population. And so this treatment recommendation was easy. The standard of care in first-line dMMR, advanced recurrent endometrial cancer patients, is clearly chemotherapy, carboplatin paclitaxel, plus the addition of immune therapy. And currently in Europe, we have the approval for dostarlimab, pembrolizumab, and for durvalumab in this patient population. It becomes a little bit more difficult in the non-dMMR population, and we discriminate here a very important symptomatic advanced disease or rapidly growing recurrent disease. So this is patients that need an immediate fast response of treatment because they have symptoms. And we discriminate this patient population from the low-grade estrogen receptor positive, low-grade asymptomatic advanced disease or the slow-growing recurrent disease. So let's focus on the symptomatic advanced disease or rapidly growing recurrent disease. And here we recommend chemotherapy also with a level 1, so highest level of evidence, and strength of recommendation A, 1A for the chemotherapy. So like for the dMMR population, the chemo plus IO was a 1A recommendation. We have here in the non-dMMR symptomatic disease a 1A recommendation for chemo. And then based on the phase 3 trials that you heard, the Ruby, the Energies 018, the Duo-E trial, we have the recommendation, highest level of evidence, all from phase 3 clinical trials, level 1 evidence for the addition of immune therapy to the chemotherapy, followed by maintenance treatment with immune therapy. And then you have equally strong recommendation, also level of evidence 1, strength of recommendation B, that you can add immune therapy to the chemotherapy, followed by immune therapy and PARP inhibitor maintenance treatment. So this comes from the Duo-E trial. So which approvals do we have in place for the non-dMMR situation in Europe to date? The IO that we can add to the chemotherapy and use in maintenance is the dostarlimab or pembrolizumab in Europe. And for the IO and PARP inhibitor maintenance, we have the approval in place for durvalumab plus olaparib based on the Duo-E trial. Our guidelines also give guidance in case chemotherapy is contraindicated in non-dMMR patients. So what can you do? If you have symptomatic advanced disease, you can use a non-chemo regimen, the pembrolizumab plus lenvatinib. This is based in the first-line setting on the LEAP trial. If you have a contraindication for the application of immune therapy in this non-dMMR population, and your patient has HER2 positive tumors, then you can add trastuzumab to the chemotherapy based on a phase 2 trial from Amanda Fader in HER2 overexpressing serous endometrial carcinoma patients. If we now briefly focus on the other group, the asymptomatic, low volume, low grade estrogen receptor positive advanced endometrial cancer patients or slowly growing recurrent endometrial cancer patients, here certainly endocrine therapy is a very good treatment option. So we are discussing now 2 first-line cases of endometrial cancer patients. The first case is on a 78-year-old obese patient with cardiovascular disease. She was diagnosed with a FIGO 23 stage 4B disease. This means she had peritoneal metastasis beyond the pelvis. The histological subtype was a low-grade endometrioid carcinoma. Molecular classification, we did complete molecular testing, revealed an NSMP, estrogen receptor positive tumor, so it's the good guy's NSMP. The patient had a symptomatic disease. She was suffering of pain. She was not eligible for surgery. And this is a newly diagnosed endometrial carcinoma, so she had no prior treatment. She is chemo naive and she is immune therapy naive. And she has no contraindication against chemo or IO. So now we look at the histological specimen of this patient.
Yeah, this is the morphology of a cancer, which is of the non-specific molecular profile. You can see the histological appearance. This is a low-grade endometrioid carcinoma. The tumor is positive for estrogen receptor. It has a wild-type pattern by immunohistochemistry for p53, and it has conserved retained expression of 2 mismatch repair proteins, PMS2 and MSH6, so fulfilling the criteria of a tumor of non-specific molecular profile.
So, else, what are we going to do with these advanced stage symptomatic low-grade endometrioid NSMP estrogen receptor positive patients? What would be your considerations on treatment for this patient?
So although she's ER positive, she's symptomatic, so we want a more quick response from our systemic therapy. So I'm not considering endocrine therapy for these patients, but as being chemo naive, a platinum-based regimen with checkpoint inhibition would be of choice. Whether to give this patient also a PARP inhibitor, for me, that's a population is a bit more difficult, the NSMP ER positive. I very much look forward. We just ended recruiting the export trial with selinexor for the p53 wild types. Very much looking forward to that data.
Excellent. So going back to our guidelines, we have in this non-DMMR symptomatic patient, we have 2 recommendations, both level 1 evidence, strength of recommendation B, to add IO to chemotherapy and followed by immune therapy maintenance. This is what you suggest in this patient else. Or we also give in the guideline the option to have IO plus chemo, and then in the maintenance treatment, IO plus PARP. So in this patient, you decide for the IO addition and not for the triple combination with the PARP. And this is a beautiful demonstration how for you the molecular subtype did influence your decision making and also the other option that might arise in the future. What's about the side effect of the treatment? So this patient indeed, as you recommended, received an IO in addition to chemotherapy. The patient developed grade 1 rash. She developed a grade 1 hypothyroidism, also grade 1 fatigue and vertigo, and also arthralgia grade 1. What are your consideration else on the side effects, on the adverse events of this treatment?
Well, first of all, point out those are low-grade adverse events. The hypothyroidism, the arthralgia, the rash, most likely related to the immunotherapy, but low grade and manageable. We always test thyroid function with each administration, so we are on the lookout for hypothyroidism, and this is easy to substitute. Okay, it's another medication for the patient, but it's easy to manage with the right substitution. Patients do not need to be symptomatic of this side effect.
Yes, so very well manageable side effects. Let's look at the same case. So also a stage 4B patient, peritoneal metastasis beyond the pelvis, but now the histosubtype and the molecular subtype changed in the patient. So she is still symptomatic in her advanced stage disease, but now this is not a low-grade endometrioid NSMP ER positive, but this is a serous carcinoma with a P53 abnormality. Again, newly diagnosed, no prior treatment. The histology looks like this. Can you give us some details, Xavier?
So this is the typical serous carcinoma. You see the morphology, papillary arrangement, very atypical cells. The P53 staining shows a diffuse positive staining, which is the typical of a mutated or abnormal P53 pattern. There is also positivity for P16, which is an interesting marker of this type of tumor. We can see that the tumor is not showing microsatellite instability, and in the bottom of the picture, you can see the chart of the mutation analysis, and you can see how there are ups and downs in this line, which shows that this is a tumor that is high copy number, which is the typical example of a P53 abnormal carcinoma.
Beautiful pictures, beautiful. Now, else, it will be very interesting to hear if your treatment consideration changed now that the molecular subtype changed from NSMP estrogen receptor positive to P53 abnormal, both non-DMMR patients. So what are your considerations now?
Although, again, trials were positive in the entire population, if we go back to the biology and you look at P53 mute high-grade serous oral carcinosarcomas, their prognosis is dismal. And what we used to do with chemotherapy, they had progression-free survivals about 6 months, 7 months, etc. At least with the trials, we have increased that with median PFSs now 15 months. We've seen the duration of response increasing from 7 months to 10 months to 18 months within the DOE. So for this patient, we all know we treat this in daily practice. They are rapidly progressive when we use just chemotherapy. So this regimen clearly makes a difference for this patient. I would certainly choose the chemo IO and then followed by IO and PARP combination.
So in this patient with the P53 abnormality, non-DMMR, you would add in also the PARP and use the durvalumab plus olaparib scheme from the DUO-E trial. Are there any hints from the trial? Because for the NSMP estrogen receptor positive non-DMMR patient, you opted for the IO addition to the chemo only. For the P53 abnormal, you now opt to add in also the PARP. Our triple European guidelines give both options for the overall non-DMMR population. So can you elaborate a little bit why in the individual patient case you make a different treatment decision within these both cases that are non-DMMR, but based on the molecular subtype?
It is, of course, looking at exploratory analysis of the biomarkers, but there the hazard ratios are the strongest within the p53 mute for the Ruby, for the DUE, and even stepping aside of this analysis, again, if I like said, if you look at the biology of these tumors and their prognosis, what we usually see in clinic with short-lived responses to chemotherapy, I think the combination really makes a difference. In the NSMP ER positive, even if we treat with chemotherapy alone, maybe we reach the same results than with chemo, and PARP inhibitors. It's a very different kind of tumor with a different kind of prognosis, even within the recurrent setting.
Okay, so your argument towards treatment escalation to add in the PARP, to summarize your arguments, is that the p53 abnormal are much more aggressive subgroup with a worse prognosis, and also that the subgroup analysis of DUO-E and RUBY Part 2 showed that in the p53 abnormal subgroup we see a hazard ratio shift to the left with the addition of PARP to the IO plus chemo. And then a third reason that is maybe worth mentioning is also the scientific rationale behind. For the PARP, if we think about the data in ovarian cancer, we know that HRD positive patients benefit more from PARP inhibitors. And we know very little about HRD in endometrial carcinoma patients, but the little data that we saw is that probably the p53 abnormal have the highest incidence of HRD. So all this together makes us rather that we decide for escalation in the p53 abnormal and adding the PARP inhibitor. These examples, two examples, very nicely show the relevance of molecular subtype. Xavier, can you point out the molecular testing? We saw the clinical relevance. What are important considerations on this?
Well, that molecular classification is important. That molecular classification should be performed completely. So that means that, of course, immunohistochemistry for mismatch repair proteins, of course, p53 immunohistochemical pattern, but also polymutation analysis, which is crucial to have this complete molecular classifications that is required for appropriate risk stratification of the patients.
Okay, and you stressed that the quality is important already to do it on the curettage material where you have very good fixation, and also when in the patient journey do you recommend to test?
So at diagnosis, that has to be done at diagnosis. But then, of course, when the disease progresses, I think it's very important to retest if it is possible, because there are changes in the status, particularly regarding the hormonal status of the tumors and also mismatch repair deficiency. So I think it's important whenever this is possible to retest upon progression.
So yeah, we have discussed interesting patient cases, and now we enter an new era of effective treatment with IO in first-line endometrial cancer patients.
Yeah, and that is truly wonderful to see that after the results of the trials in 2023, the endometrial cancer patients also have maintenance options now, like we already had in other gynecological oncology domains, like in ovarian cancer. We have maintenance therapy with PARP inhibitors and/or bevacizumab, and cervical cancer, where we also have the option for checkpoint inhibition with or without bevacizumab in PD-L1 positive patients.
So after this exciting review, of evidence, new evidence of the pivotal role of molecular classification, risk group stratification, amazing phase 3 trial result with new treatment options for our patients, looking at endometrial carcinoma today. What is your summary else?
Well, for the DMMR, we have made tremendous progression. So for a DMMR patient, you should treat with a combination of platinum-based chemotherapy and checkpoint inhibition. Whether we can lose the chemotherapy altogether in that regimen, that's still under investigation into other trials. So for now, it's the platinum-based chemotherapy with checkpoint inhibition. For the non-DMMR population, the trials also positive results for the addition of IO to the chemotherapy, less tremendous than in the DMMR population, and adding a PARP inhibitor showed an additional PFS benefit both in the Ruby Part 2 and the DUO-E trial, with manageable safety profiles in both trials.
So from my side, I would emphasize the importance of a multidisciplinary approach. And I think the ESGO S3SP guidelines is a proof of that. And this multidisciplinary approach with this integrated analysis has allowed to increase the survival of endometrial cancer patients. And in this setting, I'm proud to say that pathology is very important, and it's fantastic to work together with the other specialists in that field.
Beautiful take-home messages, beautiful summarized from the clinical point of view and from the pathology point of view. Thank you very much, Xavier and Els, for this very great discussion. And I warmly thank the audience, you, for participating in this activity. Please continue online and answer the questions that follow, and please complete the evaluation.